Hello and welcome to episode 188 of the Rollo and Slappy Show. Today is March 16th, 2020. I am Rollo McFlugel. With me as always is Slappy Jones 2. Show notes page for this episode will be mcflugel.com/188, where you'll be able to find a link to our sponsor, libertymugs.com, where you can go buy some mugs in this tenuous time that we are in. We'll say that you can use them as food, toilet paper, water, whatever you need them for, because, you know, supplies are dwindling, but we are fully stocked. So,
and because we have a $100 mug, we have some available for you.
Yes, and we won't say it does cure the coronavirus, but we have
I'm not going to say it doesn't.
We have reason to suggest it. So with that, maybe we can get a medical person, like a doctor, to kind of prove or disprove that claim. So, Slappy, do you want to introduce
today's episode?
Yeah, do you want to introduce our guest?
Sure. Our guest today is making a return appearance on the Rollo and Slappy Show, but it's been a while. And I guess this is either his third or fourth appearance on the show, because we split up our very first Bitcoin episode into two episodes with Vake Raj. Welcome back to the show, Vake.
How's it going, guys?
It's great.
Pretty good, man.
Mm-hmm.
So my first question is, there's this like rash on my arm that.
Yeah.
So I mean, I could turn on the video.
Yeah, I could. It depends. I have to take a look at it. There's like a zillion different types of rashes.
Well, this one's pretty interesting.
Yeah, it's like, what color is it? Is it scaly? Is it raised? Is it flat? Itchy or not?
Oh, it's very itchy, very red. It was after I hung out with Clark Campett for a little bit.
Oh, really? Okay,
Yeah.
well, that
could be dangerous.
Yeah, that guy sounds like he carries a lot of contagious diseases on him.
Probably.
Yep.
Sorry. So, I mean, that's all I wanted to ask you.
All right.
Yeah.
So thanks for listening, everyone. We'll catch you.
Yeah. Well, I guess let's try to get this back on track.
Yeah.
Thank you, Rollo. Appreciate that.
Mm-hmm.
There's been a lot of talk out there. Well, not a lot. It's all been about coronavirus the last week or so, maybe a little more than that. Every time I go on a news website, it seems like every single link is to something about coronavirus. Someone got infected here, and maybe someone died, and then it leads to discussions sometimes on Twitter about what would be better: universal health care, free market health care. The United States has free market health care. We're going to talk about that a little bit, and just some of the bureaucracy and some of the holdups in the system by someone who actually works in the system on a daily basis. So Vake's going to give us a little guidance on that. First of all, how much, I'm just going to put it out there, how much of a market for healthcare is there that you are aware of in the United States?
It's very, very limited. There's pockets of a market, like you could say, things like plastic surgery is, because it's not covered by insurance or Medicare or Medicaid, there is a market for that. But most things in healthcare are highly regulated. They're subsidized through third-party payer programs like Medicare or Medicaid or insurance companies. It's controlled by the government from every aspect. So you're dealing with a large amount of bureaucracy. Things just aren't as simple as they would be in a normal market interaction where, the seller provides some good or service and the consumer just gives them money. There's a whole layer of rules and bureaucracy that just interrupts that normal market function.
So let's get into that a little bit. So here's an experience I had. My son had to have surgery 2 years ago or so. Mm-hmm. It was a minor routine operation, nothing crazy.
Yeah.
But when we looked at our insurance and the plan I'm on, there's different tiers of doctors and facilities. And we called the doctor's office, we called the insurance company. They confirmed these are going to be the codes we're going to bill. We went to the insurance company. We told them who the doctor is, what the facility is. They're both tier 1. This is great. It's all covered. You have a copay. Great. Then I got a bill for $1,500, and it turns out the anesthesiologist or anesthetist, whoever it was, I don't remember, was not in network. So I had the facility and the doctor. We were good, but then the anesthesiologist wasn't, and so he was like tier 3 or something. So I had to pay a stupid amount of money for that. Is that something that you have any idea about as a doctor? Because it was my kind of feeling that, like, the doctor's there, he's just doing his job. And what happens with the insurance is just kind of there. You know, like, he's going to show up and he's going to treat his patients and he's going to go through it. And it's the, you know, and then people get mad at the insurance company, and why wouldn't you? I mean, we thought we checked everything. But I'm throwing this out there, and I know you have limited details, but how do you explain that? Is this common? Do you know about this?
I don't know, I mean, a lot about the surgery area, how much that happens. It definitely happens in ER. Like, if you go to the emergency room, whatever, and they discharge you back home, you'll get a bill from the emergency doctor, who ER doctors are kind of like freelancers a little bit because they might work at a lot of different hospitals. You'll get a bill from the radiologist if they give you an X-ray or a CAT scan, and then you'll get a bill from the hospital itself. It's broken up. But like you're saying about the insurance company, I feel like insurance companies, they definitely shoulder a lot of blame for the way things are, messed up things are. They're also unfairly blamed, or particularly people on the left, progressives, they blame insurance companies for everything. But the reason is that the insurance companies are put in a very awkward position because they're the people paying for all the healthcare, right? Well, people give them premiums, right? And then the company pays it for all the services that are rendered. But because so much is being billed to the insurance companies, probably above and beyond what they can even afford to pay, or else they go bankrupt, they're kind of turned into the bad guys because they're the ones having to tell you, no, you can't have this. No, you can't get that. So they're put in a very awkward position. And there's the root of the problem is a lot deeper than insurance companies. It's a big chunk of it is that we're relying way too much on third-party payers for our healthcare expenses, when a lot more of it should be out of pocket.
Yeah, totally agree. I mean, one of the I guess analogies people make is like with car insurance. Like, car insurance would never cover your oil change or your new tires because that's wear and tear. That's not a risk. That's not an insurable risk, you know. And they would never cover it. It wouldn't make sense. It would just be a cost sharing type program. Yet that's exactly what we see in the healthcare market. And is that? Yeah, I am in the insurance industry, but I don't do health. I mean, I'm health licensed, but I don't sell health. It's not what it's not my thing. I don't know a whole lot about it, but I'm assuming that is not due to insurance companies trying to provide more services for their clients. Of course they would, but that's not an insurable interest. So that has to be mandated from the state, I would assume. Otherwise it would make no sense to do it.
I think that insurance definitely has a role in covering against catastrophic expenses. So hospital admissions, surgeries, things that you cannot predict. But a lot of the outpatient medical care should be out of pocket. So it's your doctor's visits, your routine prescriptions, your routine labs, things like that. You should probably pay out of pocket. And so people are naturally inclined to think, oh, well, how can people afford that? You know, drugs are so expensive, x-rays and lab work and all this stuff adds up so much. But the reality is that the cost inflation is because we are relying so extensively on third parties that we've become less price sensitive. We don't shop around. We don't
even ask.
No, not really. Yeah. No. I mean, so they go for, they don't discriminate in terms of price. So they just overconsume healthcare to some extent.
Yeah, it's kind of funny. I had to take my cat to the vet a few months ago, and with like the prescriptions that they wanted to give him for trying to solve whatever he had going on with him. It was like, well, how much does that cost? And she said, oh, give me a second. She pulled her book out and said, it's going to be this.
Yeah.
And so it was very nice. And I was able to sit there and it's like, oh, okay, that's reasonable. And if I didn't want to, I could have, done something else. But on that note, because you kind of mentioned it too, what's going on with prescription drugs? Because those tend to keep going up in price higher and higher. And it's a real difficulty for a lot of people, especially people who are older who have a lot of prescriptions that they have to purchase and stay on. Do you have any insight on what's going on there?
Yeah, I mean, I think there are some affordable medications that are no longer patented. But yeah, I mean, you're right. There's a lot of drugs that are going up and up in cost. It kind of depends on what specific medication you're talking about and whether it's still in that patent window. But I mean, prescription drugs, it's such a messed up area. You might you might send a prescription for somebody to the pharmacy, and then they get there and they found it covered, and then the pharmacy has to send you a fax, and you'll have to try some alternative medication, or what doctors will often have to do is something like prior authorization, where you'll have to call up the insurance company and spend half an hour or 45 minutes on the phone with them, just explaining why this particular medication is necessary for that person. So yeah, it's a whole bureaucratic mess. I mean, if anybody who's had to sit at a pharmacy and find out that their medications aren't covered knows this. But some medications you can get for relatively cheap. Like a good example of that is metformin, which is kind of a very standard diabetes medication. But then often, in the news you're hearing about insulin being so expensive. So that's probably, there's a lot of different types of insulin. There's the short-acting ones and the longer-acting ones. The ones that are really expensive is the long-acting ones like Lantus or Levemir. Those get rejected pretty often. And so people will have to, switch to the short-acting insulins, which they have to administer multiple times in a day.
When you say they get rejected, do you mean by the insurance company?
Yeah, by the insurance company. They won't
pay for it.
They won't pay for it. There's another class of medications. Some people need blood thinners because they have a history of blood clots in their legs, or they get pulmonary embolisms where the blood clot ends up in their lungs. So they need to be on what we call anticoagulation. There's a new class of anticoagulants called NOACs, novel anticoagulants. Like you might have heard of these, like Xarelto, or Eliquis, or Pradaxa. So these are excellent medications because they'll thin your blood, and you don't need to check what we call your INR, which is a blood type measurement for how thick your blood is. You can just take the medications and they automatically self-regulate in the right range. But they're still all under patent protection. So they're still very expensive. So if your insurance company doesn't cover them, they're probably prohibitively expensive for most people. Luckily, the older drug is warfarin. So that's the classic anticoagulant. Yeah, that's been around for decades. It's pretty cheap, but it has a significant bleeding risk because you have to constantly monitor your INR and make sure that your INR stays in the exactly right range, depending on what your condition is. So a lot of that kind of depends on just the patents, whether they, obviously a patent, as we know, is a monopoly on the production of that particular good. So there's only one provider, so they can charge monopoly prices.
Do you know how long they last in the medical world? Is it just like any other patent?
I've read like 17 years, but I don't know a lot about it. That's probably a legal question.
Yeah.
For quite a while. So I think it's just a combination of dealing with the insurance approvals, the exclusive monopolies that kind of drives up the cost of prescriptions. A lot of people who can't afford their medicines, they just won't take them, and then they end up in the emergency room. Then the cost is manifesting in the system through, increased hospital prices, to for these uninsured people or Medicaid patients. Yeah.
So, all right, you mentioned Medicare, Medicaid, and how it, a third-party payer, people don't price shop, it's paid. Could you just briefly, as simple as possible, because I know there's a lot of people listening who we all have heard of Medicare and Medicaid, don't know what the difference is, don't know what it is or how it works. Could you just give a brief overview of what they are? And then one thing I'm not sure of are Medicare, when you're covered by Medicare, are they pre-negotiated prices with hospitals and the government, or is it if this is a Medicare patient, we know we can only charge X or whatever? Could you just talk about that a little bit?
Yeah. So obviously Medicare and Medicaid are both government programs. Medicare is generally for people age 65 and older. And then Medicaid is for low income persons. They're generally state-by-state programs. Both Medicare and Medicaid partner with outside companies. So it's Medicare, they call those Medicare Advantage plans. And then Medicaid has these other supplemental plans. I don't know what the specific term for them is, but they'll partner with outside insurance companies. And then apart from those guys, you have the private insurance companies. So United Healthcare, Aetna, Cigna, there's others,
Yeah.
Blue Cross Blue Shield, of course.
Right.
Yeah. So in terms of reimbursements, from what I understand, based upon my conversations with people in the financial side of healthcare administration, typically a hospital will have negotiations every, one or every few years with insurance companies, and they'll have set rates for particular admissions. So, if somebody comes to the hospital with pneumonia or COPD exacerbation or, diabetic ketoacidosis, there will be a fixed reimbursement for that diagnosis.
Okay. So I go in with, whatever it is. There's a fixed rate. It doesn't matter where I go, what city, or is that all kind of state by state?
Well, it's generally negotiated on a local basis.
Okay.
But then, every person, there might be a primary diagnosis, but then you also have your other comorbidities. So this guy came to the hospital for pneumonia, but also we're treating his diabetes while he's here as well, and his blood pressure. So the hospitalist, the doctor, is supposed to, list all the diagnoses, and then you have your consultants, all the specialists that see the patient as well, and everybody has their diagnoses listed. And then the hospital employs coding specialists who read the doctor's notes, and then they translate that into coding that they submit to the insurance company. So and a lot of times,
another layer of administration that goes into it. Yeah,
absolutely.
Got to protect those jobs.
And those coders will, if you're a hospitalist, so the inpatient doctor, they'll bug you, because if you don't phrase the diagnosis properly, then
doesn't get reimbursed properly.
Exactly. So, an example I'll give you is you can't say congestive heart failure. You have to say systolic or diastolic congestive heart failure, which are generally the two types of heart failure. Yeah, sure. You have to say what the ejection fraction of them there is, which is just the strength with which the heart pumps out the blood. It's a number, 45%. So they'll kind of ping you to get these diagnoses right, so they can submit it to the insurance company for reimbursement. And then the insurance company will take a look at that those claims, and they'll reimburse the hospital a certain percentage, And then the same thing happens in the outside, the outpatient world, where you'll see the patient, you'll list all your diagnoses, and then you have to code the visit. So, example, in the whole coding it's so complex. It's a whole other world you have to learn on top of medicine.
So it's probably another language. It's
another language. So there's different types of codes for outpatient doctor's visits, like 99213 visits, 99214. There's these numbers you have to memorize, and then you submit. You select it based on the complexity of the care you deliver, and then you submit to the insurance company, and then they give you back some percentage. I was talking to our residency clinic's practice manager the other day, and she was telling us how they might submit a $212 charge to the insurance company, but they only get like $75 in payment. So
where do they make up the rest? Or do they just don't? Or they bill the client, bill the patient?
So our clinic is actually loses money. Loses she told me we lose probably $40,000 to $50,000 every month, but the parent company of the clinic doesn't mind because we're like a supplement to the hospital.
Right.
So the goal is to keep patients out of the hospital.
I was going to say, it's like almost like a loss leader, right? Like, even though we're losing money, it's worth having it because our profitable business performs better.
Yeah. If you can keep some of these patients out of the hospital, it has some benefit overall to the bottom line.
So now with Medicaid, that is for low income, and I guess you have to do some kind of asset test or something to prove that you qualify for it or whatever.
Yeah.
But do you know that when they come in the hospital, I know there's laws that you can't turn away patients. And to be honest, I wonder what your feel on that is. If we had a free market, doctors are people who generally, at least in my opinion, and you might laugh at this, I don't know, but generally dedicate their entire lives to helping people. In a free market, I'm sure there would certainly be instances of patients being turned away, especially by certain doctors who are in high demand. But I do believe there would be a fit for them somewhere, and I do believe there would be plenty of free medical care. But my question is, when someone comes in the hospital, you have no idea if they're covered or not, or if you're going to get paid for your services or not. How does that go? You just don't even ask, or are you not allowed to ask?
Well, yeah. Hospitals cannot turn away patients, like by law. There's a law called EMTALA, EMTALA, which is the Emergency Medical Treatment and Labor Act. So it basically says that hospitals or an emergency room cannot turn away a patient regardless of ability to pay. They have to be evaluated by a physician. If they necessitate, their health condition necessitates admission to the hospital, they cannot be turned away. You cannot dump them on another hospital, by transferring to another hospital. You cannot tell them, hey, leave this ER and go to the ER at that hospital down the street.
Why is that? Just because it could be an emergency, they need treatment now? Because if you're at capacity, why couldn't you say, we're full, go somewhere else? That just sounds crazy to me. Yeah.
So the only condition upon which you could transfer somebody to another hospital is if they need a higher level of care or a certain specialist is not available at your hospital. So the hospital I work at, there's 2 other hospitals nearby in our area that are owned by the same parent company.
Okay.
And our hospital has obstetrics gynecology, whereas one of the other ones doesn't. So if, say, I don't know, hypothetical, a 25-year-old girl is pregnant and she's having vaginal bleeding, the ER at that hospital will transfer the patient to us.
Right.
But that's only if there's some specialists that they don't have access to there, or just some general higher level care. And they do this to prevent, and you can't tell a patient to go to another ER somewhere else, because they do this to prevent hospitals from dumping patients on one another.
Sure.
So basically you have to treat the patient. Really, you don't even know the patient's insurance status. I can look it up. It's readily visible, but it's not really a concern. You just get a call from the ER and say, hey, you have a patient that you need to admit.
There. You go work. Yeah.
Mm-hmm.
Yeah.
There's generally 2 types of doctors that admit patients to the hospital. There's the hospitalists that are the doctors that work for the hospital, or a group contracted by the hospital. But in general, they just work for the hospital, and they're salaried. They exclusively work in the hospital. And then you have more like community physicians who are like primary care doctors out in the community.
Sure.
And they will have their own population of patients. And when their patients go to the hospital and need to be admitted, the ER doctor will call them and say, hey, your patient is here. I need to admit them. And then they'll come in and they'll manage their own patients. But those patients will generally be insured because they have a primary care doctor.
Right.
So, and then the primary care doctor, takes their insurance. So they have an established relationship. But the hospitalist will take all of the uninsured patients, all of the Medicaid patients, and so forth. All the patients
essentially,
that are out of town.
The hospitalist shows up to work that day, and you deal with whatever patients are there.
Exactly. Yep. Yeah. I mean, if there's a patient from some other state or city and doesn't have his PCP nearby, then they'll go to the hospitalist. So they basically take what's left over.
Right.
So do you think outside of the law that you mentioned, the EMTLA, that hospitals would try to dump patients on each other? Like, it doesn't.
I definitely think that's possible. If hospitals were required to admit patients, but they could send them to other hospitals instead, then in that scenario, yeah. But what EMTALA does, in effect, is it allows patients to, if they don't take care of their medical issues outside the hospital, they're not following with their doctor, they're not taking their medicine, they wait till things get really bad and they show up in the ER, and then they have to be admitted. I mean, I've seen patients who are, for example, who have really bad diabetes. And when you get really bad diabetes and it's in advanced stages, you can get gangrenous ulcers on your legs. Yeah. You'll lose sensation in your legs. And so, I've seen a patient who, she wasn't taking her insulin. For one reason or another, maybe she couldn't afford it, or maybe she was in general non-compliant, and then she was starting to develop ulcers on her legs, and then she had to be admitted and had to get surgery to remove these necrotic ulcers. So it kind of creates a system where people don't take care of their routine medical issues, and then they let things get so bad that they have to be admitted. They have to show up in the ER, and then they get free care that way. But it's almost like waiting for a problem to get really, really bad, and then treating it in the most expensive manner possible.
Yeah, it's interesting because it kind of takes away that the responsibility from yourself, like you said, just to take care of it early, because you're not dealing with the actual cost of your poor decision making. And on top of that too, just the general idea of hospitals just turning people away. It's I don't know of many businesses otherwise that are pushing customers out of their buildings.
Yeah.
Normally they're trying to do whatever they can to maximize.
Well, I could play some devil's advocates, and I'm sure this is what you would get. It's if someone who obviously has no money walks into a Maserati dealer, and the Maserati dealer is going to say, beat it, go somewhere else.
Yeah. These are people that can't afford to buy the product.
Yes, exactly. But they need that product, being healthcare. So how do you think, or do you think, a market could handle it better?
Yeah. Well, going back to the EMTALA for a second, it does create a situation where hospital bills are so expensive because so much of, if you're the person with insurance, part of your insurance goes to subsidize the people who get free care.
Right.
There's a lot of people in every hospital. There's a lot of people who are just charity cases. The hospital writes it off, and then they make it up by charging the insured patients and the Medicare patients more. So generally, you have the uninsured patients, the Medicaid patients that do not reimburse the hospital sufficiently, and so they make up the margins elsewhere. So that's part of why the cost is so expensive. So you're asking me, Slappy, if I think that markets can be more effective in healthcare than?
Yeah.
Absolutely, but there's not any one quick fix. I
believe that. Yeah, totally believe that.
I think EMTALA should be repealed simply because I don't think you can't go to to the Gap and grab a T-shirt and then say, oh, I can't afford to pay for it, but I'm going to keep the shirt anyway. But you can do that for medical care in a hospital. You can receive treatment and not have to pay for it.
Right, and you can't take it back.
Yep. I'd get rid of prescriptions and make all medications over the counter.
Now, how do you think the market, do you have ideas on how they could handle that? Because you know what people will be saying is like, then people will just be buying Percocets all day and, popping perks. How do you think a market would handle that? Do you think you'd go to your doctor would recommend you take something and then you just go buy it?
Yeah. I think that medicine should be purely just recommendations. I don't think physicians should act as gatekeepers.
Yeah.
And every doctor that you tell this to will disagree with me, but because that's how they make their money.
Right.
They make their money off of being gatekeepers in medicine.
Sure.
And a lot of people can't afford their medicine, or rather they don't get their medicine because they can't afford to see the doctors. So there's nobody to prescribe them the medicine that they need. And so they end up going without it.
Right.
And that's another population that ends up in the emergency room. So that's a prescription. So basically turn every medication into an over-the-counter medication. Another huge issue.
So before we jump off, I still want to kind of peek into that issue a little bit, making everything over the counter. Like Slappy said, like with Percocets, do you think that it would be like more on the pharmacist to try to like figure out or help the patient? Like if someone walks in and just is like, yeah, I'm going to buy 800 pills of Percocet. How do you think that, or just like general? I mean, I don't want to call it. Well, there's plenty of drug abuse, potential on prescription
drugs. Well, people get it all over the street. Yeah.
Yeah. Well, that's certainly true.
Yeah, I mean, it's just like the war on drugs. I mean, should people be allowed to purchase cocaine, heroin, LSD?
Yeah.
Or should it be a tightly controlled thing that the government prohibits?
Right.
Yeah. I mean, no arguments here, but just trying to throw out what people may, like that. When I talk to people about being an ANCAP or whatever, and those are always the things that come up. Well, what about you just want anyone to go in and buy heroin? It's like, I don't want to throw them in a cage if they do. Like,
that's what things like. I mean, the opiates. That's what they're heroin. They're the same.
Morphine and
the chemical. Yeah. They're basically oral forms of heroin. And that's why we hear about the opiate crisis a lot lately. I mean, I don't have any evidence to back this up, but I suspect a lot of it is people that used to do heroin are just taking Percocets now, or Norco, or one of these other opiate medications. That's what I think is happening. That's just one drug being substituted for another.
Right.
Yeah, well, it's like and I think this is going to be the theme for a lot of stuff we talk about, because like you said, there's not one silver bullet. There's a lot of issues, but I mean, you do away with the war on drugs. You let cannabinoids and things from marijuana start being used instead of these like synthetic heroin. They're literally heroines or these opiates out there, and I think that problem kind of fixes itself because. I mean, I know.
If you talk to heroin addicts, they don't always love being heroin addicts.
Right, and two, how many
get off?
And to the I think there's a case to be made that the opposite happens too. Like what you said with heroin users, a lot of them get started by getting hooked on prescription drugs.
Yeah,
it's really
absolutely.
Really nasty.
Yeah, I mean, I do think that there was a role for these Percocets and similar medications, just because, I mean, and morphine, Dilaudid, just because, for post-op patients that are in severe pain, they need something a little stronger than Tylenol.
Yeah, absolutely.
Right. So.
And so, yeah, like I agree. I think there would be a need for it. Here's a question on the same topic. Do you think, given the way the system is today, do you think there is, and maybe you don't want to say, or maybe you don't know, but do you think there's over prescribing of drugs to kind of be safe? Like, better be safe than sorry, don't want a malpractice lawsuit, or you get paid for prescribing, so we'll prescribe a little more. Do you think that happens?
I don't quite agree. You're not actually paid for prescribing. So I don't really kind of buy into a lot of the conspiratorial stuff here. Mm-hmm. What happens is it's sort of a too many cooks in the kitchen problem. So you'll have your primary care doctor might start you on a medication for your elevated cholesterol, like a statin, and then blood pressure medication. And then what happened is, you're also seeing a urologist because you have, I don't know, an enlarged prostate. So he'll start you on something Flomax to help you pee. And then guess what? You're also seeing a cardiologist because, I don't know, maybe you had a heart attack 4 years ago, and he starts you on, I don't know, a beta blocker, which is another blood pressure medicine, but it's a little better in, people with coronary artery disease. And he might start you on, another medication to lower your risk for a repeat heart attack. And so you're seeing like 4 different doctors, and then you go to the hospital once for, I don't know, an asthma exacerbation, and then they start you on albuterol. And then what happens is all these medications just get piled up from these different sources, and they get continued, and then they don't go away once they get added to your list of meds. So
is that why all those drug commercials, they say like, tell your doctor what other medications you're on?
Yeah, that partially. What a good primary care doctor should do is routinely try. I mean, I try to do it, but it's easier said than done. Is try to get rid of the unnecessary meds. Mm-hmm. But a lot of patients just have a lot of medical issues. They have diabetes. They have high blood pressure. They have high cholesterol. They've had heart attacks. They have COPD because they spent a lifetime smoking. So you have if you have 1 or 2 medications treating each of these things, eventually they're on a dozen things.
Yeah, and I think because I know I've gone to the doctors before, and it felt, and I don't want to sound like I'm being critical of the entire industry because this is just my sorry, my singular experiences, and also might be not in my lane since I'm don't have any medical expertise. Mm-hmm. But I felt like, you go and I say, oh, I've got this issue, and it's like, all right, we're going to try you on this medication. It's like, well, wait, what about trying to diagnose? And then, because I was on, eventually got diagnosed with migraines, which I kind of knew I had, but first went with moxiclavin to see if it was an infection, and then steroids, and then got a CAT scan to make sure that I didn't have a brain tumor crushing my skull or something.
Yeah.
And finally got sent to the specialist who put me on an Imitrex type thing.
Yeah.
But yes. And at no point did I ever feel like it was anything other than just well, we'll just treat you with medicine instead of trying to figure out what's going on. I don't even know what kind of question that, how to make that.
Yeah,
question,
no, I mean, you're trying to.
Is that your perception? What? Yeah.
Yeah, I guess that's kind of my perception of how it goes down for me a lot of times, and I want you to tell me that, you just had a bad doctor or something, or I don't know.
Well, I mean,
or is that the only, or is that really the only way that you can kind of do it? It's kind of, I don't know.
Well, I mean, at the risk of sounding critical, the people who bitch about doctors prescribing too much, doctors just want to throw a pill at everything. What do you expect?
You're practicing medicine.
I'm practicing medicine. It's like blaming a waiter for bringing you food.
Right.
Fair enough.
At the end of the day, I mean, a doctor, what are the things you could treat people with? You can, if they have pain or something, you got physical therapy, there's surgery, there's, I don't know, joint injections or trigger point injections, and then there's pills. I mean, what else can doctors do? I mean, you can, sometimes I've seen people on Twitter complain that doctors don't counsel people on diet and stuff more or exercise. It's why do you need a doctor to tell you to eat healthy? That's not a secret.
Right.
You don't need a doctor to tell you to hit the gym.
Yeah, I mean that.
I do have mirrors. They work well too.
Well, part of it too is that help yourself out.
Exactly.
Or if you're going on 15,000 medications because you're seeing 15,000 different doctors, and maybe you open your mouth and say something. Hey, by the way, I'm on these other medications for these other things. Is this going to cause an issue? Because if the doctor, he might ask, but if you know information that might be relevant to his decision making, then don't hide it.
Yeah, I mean, I just think, it's not so much an issue with younger persons, but people that get up in their 60s and 70s and 80s. By that point, they start to have multiple medical problems, and they need medications to address each one of them. There's no one pill that fixes it all.
Right.
But another issue with this is kind of how the electronic medical records don't really sync well between hospitals and doctors' offices and pharmacies. So you kind of have to figure out what medications a patient is on simply by asking them. And a lot of people are totally clueless.
I have a question on that because in the notes you sent over, you mentioned HIPAA and how the medical records are not synced. Now, in my industry, when we do life insurance or disability insurance or long-term care, we have to get a HIPAA authorization signed, which is essentially authorizing us to go get their doctor records. And that's really my experience with HIPAA is we get this form signed. We have to have this form in order to see the records. And anyone who wants to see those records, be it the underwriter at the insurance company or the producer, has to have their own HIPAA authorization signed, which is really kind of a pain. But I can see that some guy applying for insurance doesn't want me to have his medical records and passing them out to his producer, his agent, who he may not want the agent to know what's in his medical records for whatever reason. So I understand why you would need the authorization, but HIPAA is a big issue in the medical world. And what is that about? I mean, how do you handle HIPAA? How does that affect your day? Like, what goes on there? Because I'm totally clueless on. It
just means that everything, the technology is 20 years behind the times. You're still faxing things to each other. So if I have to figure out, if a patient's also seeing a cardiologist, I have to fax them. I have to get the patient's signature and then fax that to the cardiologist, and then they fax back all of their records, and then you have to literally go through it like on paper and read their notes. Is
that because they're afraid like an email will get hacked?
Exactly. Nothing is sent via email.
Right.
So, everything is just fax based. Even if a patient, I wanted to give them, an order for go to LabCorp Quest and do some labs. Mm-hmm. I can't. You're not allowed to email it to them. They either have to come in person to the office and pick up the lab order, or you fax it to them. So what it does is it just creates mountains of paperwork. None of the systems are integrated between hospitals and clinics.
Right. So you can't.
Exactly.
Share that
information. Is that the problem that Dentacoin solves?
Oh, exactly. Yeah, Dentacoin. It's yes. They're
the most useful medical records on the blockchain.
I was going to say, I'll bet you could add that to TractorCoin, RV, cash, whatever it is. You could add medical records to that. Couldn't you do that on that TractorCoin chain?
We put. I'm not sure how relevant medical records are for TractorCoin Cash RV, but we do put like oil change records, and also last time you fill up your gas tank, that kind of stuff.
So you know when it's empty.
Belt history, all that kind of stuff.
Mm-hmm.
Good.
But basically, I mean, it's just the EMR systems in the U.S. A lot of the electronic medical record systems are very user unfriendly.
Didn't Obama try to do something with that? Or am I wrong? I thought I remembered hearing about records becoming electronic, or maybe it was in Obamacare or something.
Well, the issue is that the records aren't electronic. It's that every provider, be it the hospital, your primary care doctor, your cardiologist, every one of them has a different system, and they're not connected to each other. So, as a primary care doctor, it'd be helpful if I knew what the cardiologist is doing. But I can't, so I have to fax them, and they have to fax me back, which just creates loads. It creates loads of paperwork.
Yeah. So here's something for all you doctors out there. Being in the insurance industry, when your patient comes in and you ask him a question like, are you feeling stress or anxiety? And he says, yes, because my job or whatever is busy, or my family. Could you please add another note to say, like, normal anxiety, because that goes to the underwriter and then they put all kinds of exclusions on it because like, this guy has an anxiety problem. And then we go back to the client and the client goes, what are you talking about? And then we have to say, it's in your records, anxiety is checked. So being somewhat sarcastic, be careful about the notes you put in that file, because your patients, when they apply for insurance, just at the bottom, just put he's in ship shape, everything's great, and there should be no issues getting insurance. And that'll make my life a lot easier.
Well, is it just listed in like the text of the history, or?
Yeah, well, sometimes there's more notes. No, sometimes there's diagnosis. Sometimes it'll say like, you're going back through the records and it'll go, why is he here? And it'll write something like, I don't know, feeling anxiety with work and new baby, or just got married, bought a house, and just that little thing, even if there's no prescription. Or I don't know if it has to be an official diagnosis or what. But a lot of times underwriters will be like, well, it was back in December of 2019. He is the first note we see he's feeling anxiety. This could be an issue, which is more on the underwriter than the doctor, just trying to take care of his patient.
I mean, unless it was a formal diagnosis that they're being treated for with some medication, that seems very strict.
It is. It's crazy, actually. It's insane. But that's a insurance thing with underwriters that I have issues with, not doctors.
Yeah. Oof. That's a bad deal.
I might have missed this when we were talking about the EMRs, and you mentioned that there's like each insurance company or whatever system, they their own systems don't talk to each other very well.
Yeah.
Is that I might have missed if you said this, but is that because of the HIPAA stuff that they can't? You're legally not allowed to like talk very clearly about that kind of stuff?
I think that's why everything has to be signed off by the patient before you can request the records. You have to get their signature. That's why you can't just be sharing records between offices, or why you can't have integrated medical records, is because the risk of leaking those records would produce a massive, legal liability thanks to HIPAA.
Okay.
Right, because there's very stiff penalties for leaking records. Ironically, there is one system that is the exception to all this. Can you guess what it is? One hospital system.
VA?
Yep, yeah. Slappy got it.
Got it. Ding.
And because the VA is, as a government agency, is effectively
can't do wrong,
unsuable. Yeah. And they have had numerous hacks in their
that's crazy
in their history. Yeah.
All right, so here's another thing that gets brought up. Maybe switching gears a little bit, but we hear high costs of medical care due to malpractice and malpractice insurance. As a libertarian, I think malpractice is something that doctors probably should be liable for if they're doing something egregious or negligent, or that they shouldn't be doing. This is going to be a broad question, but how much malpractice suits that, go to trial or whatever, or get settled, are frivolous, in your opinion? And I know that's probably impossible to tell without having any kind of data or any kind of guideline, but just as a general feeling, like when you're treating patients, are you concerned about that? Like, maybe this guy's going to try to sue me and get money, and then I'll have to settle because it's not worth going to court, whatever?
I think it's a non-negligible percentage is frivolous, because obviously, if you imagine a courtroom scenario, you've got a patient, somebody had died, or maybe they're paralyzed because of what is perceived to be an accident or poor care by the doctor, but really there's more to it than that. It's very much specialty dependent. Like one of the really well-known areas that you have a lot of legal liability, malpractice liability, is OB-GYN.
Yep.
Their malpractice rates go through the roof because
I know an OB who retired because his rates is stupidly high.
Yeah.
So he just retired.
Another one, one of the areas of medicine I have a lot of respect for is ER doctors, because an ER doctor is the front line of medicine. Like they have to see everything from children to adults. They have to, do a lot
gunshot wounds to a guy who's got a cold.
Yeah, exactly. I mean, if they're a trauma ER, gunshot wounds.
Sure.
There's a lot of legal liability there. There's it's a field where if you make a mistake, there can be very severe consequences. Whereas in most other industries, that's not true. If a waiter screws up an order, no big deal, right? So
right. Well,
I mean, I'll give
stakes
you a
are high
example.
as a doctor. I mean,
this was a case I saw probably 2 months ago. I was on ICU. There was a woman who was admitted overnight for stroke-like symptoms, and the doctor that saw her in the ER, apparently she had some weakness on the right side of her body. She had like that facial droop and was slurring her words. And when the doctor in the ER saw her at that time, the symptoms were not particularly severe, and they'd already been present for, I think, 9 hours or something. So she was out of what we call the window for a medication called TPA, which is a clot buster. And so they didn't push the medication. And then her symptoms got worse overnight after she was already admitted. So by the time I saw her the next morning, she clearly had the signs of a stroke. And so because they didn't give that medication, the ER doctor is now liable to be sued. So I don't know. It's kind of hard to say. Yeah. It's an area where if you make a mistake, you can.
Even if it's a mistake that, so I don't know what the hell the law was do this. What if in hindsight it's a mistake, but at the time, given the doctor's information, he was doing the best he could, which I imagine happens most of the time. The doctor is doing what he thinks he should do, what is best for the patient, and then hindsight 2020, it didn't take, or the medication was wrong, or mixed with something he was not aware of. You see cases like that going forward, because my general feeling for doctors is that they want to provide good care for their patients. Otherwise, they wouldn't dedicate their entire lives to doing it.
There are some lazy doctors out there.
I'm sure, just like anything else.
Yeah.
But I'm saying, generally speaking, I maybe I'm wrong. You're in the lunchroom with them.
Most of them are trying to do a good job. I just think, there can be significant consequences if you make the wrong decision. And but it's just one of those things where if you slip up just a little bit, you can, and especially in ER where you see dozens of people in a given day, and you're at any given time you might be actually taking while they're seeing that patient, they're also taking care of another 6 or 7 guys in other rooms. So they're constantly multitasking. So you don't have a lot of time on your hands. You have to make your decisions very quickly, and I know it's tough. So ER and OB-GYN are definitely 2 areas. But the issue with medical malpractice is that you're not always being tried by a jury of your peers. You're being tried by
we've had plenty to say about that for sure.
Yeah. So I mean, sometimes you wonder if the layman can kind of
understand what's going on.
Exactly. And do they understand what the actual standard of practice is?
Well, the answer is no.
I think that's a really fair and important point, because I just know in my industry, as an engineer, I work in the petrochemical stuff, and every once in a while, the places that I work or places that I work at end up in the news for some sort of issue that happens, and just like the average person that reads it and is talking about it just has absolutely no concept of anything that we do or what standard protocols are or any of that. And it's all, those guys are evil and just out to make a buck, and they took shortcuts and were lazy and are bad. And I can only imagine how similar that is for So
But
a
just
doctor
because
who's
people
like
don't
trying
understand engineering doesn't mean that the engineer wasn't bad.
Yep. So what in medicine what's led to is you've probably heard the term defensive medicine.
Yeah.
Yeah. So there's a lot of testing done for just purely because even if you know that it's probably nothing,
Just trying to cover your ass.
oh yeah, and you'll see this happen every day in every ER. Somebody will come in and say, "Oh, I have a headache." They get a CAT scan of the head because
Yeah. Yeah.
that would happen to me then.
because yeah, I know because if the ER doctor misses a brain tumor or a bleed or something,
That's
then their license is on the line. So there's a lot of unnecessary testing that goes in just to rule out things that are unlikely. And even that goes back to the fact that people don't pay for their own health care. If you went to an ER and you said, I have a headache, and the doctor said, okay, well, to be safe, you should get a CAT scan of the head, but it's $1,000. If your insurance is paying for it, or if you're uninsured and it's being written off by the hospital, they're absorbing the cost of it, then you don't have to, then you say, well, why not? I'll just do it.
Yeah, might as well, right? Throw it on there.
So a big part of the problem there is the third party problem, the third party payer problem.
Yeah, we actually, when we take our kids to the doctor, or I rarely go to the doctor, to be honest, but I always ask the price just for the hell of it, just to see what they say. And I've never gotten an answer. It's always, I'll get back to you. Because I know they're not going to know. Because as I understand, like doctors, maybe you're trained or taught this in med school, but it's not about the price. It's about the care. So don't even worry about that stuff. Just go do your job.
Yeah. Well, what they do is they have, like, at least in terms like screening for things like breast cancer or colonoscopy, they do have recommendations like you don't start mammograms typically until 40 years old because even, could a woman in her 30s get breast cancer? They could, but the incidence is so low.
It's not likely.
Yeah, it's not likely. Colonoscopies, you generally don't start till you're 50 unless you have family history of it.
Still got a few years.
Because colon cancer is relatively uncommon under the age of 50. Lung cancer, you generally don't start screening until 55 if they're a smoker. The PSA test.
Mm-hmm. That's prostate, right? Yeah,
exactly. We don't even use that anymore unless they're symptomatic. We don't routinely do it anymore just because there are too many false positives.
Huh.
So yeah, too many people were just basically they were having to do unnecessary workups. So if you're symptomatic,
then it's worth checking.
If you're having urinary difficulties or something, it's then you might get it, but not otherwise, not as a routine test. So that's kind of how they do incorporate cost consciousness. But yeah, you're right. There's very little cognizance of what the cost of things are.
Another thing I'll bring up, are you familiar with these, like, I know Tom Woods, it was a couple years ago, he had a doctor on that was out somewhere in the Midwest maybe, who does like a concierge service. Are you familiar with that kind of practice, or do you have any idea what I'm talking about, where essentially the guy almost charges like a gym membership, and so he limits the number of patients he can have at any time, at any month or whatever, and maybe you pay $50 a month for an adult, $30 a month for a kid or whatever, and then you have access to the doctors, and he does the prescribing, and he negotiates his own prices, and he was talking about how some drugs are way cheaper if he goes direct to the supplier than if he goes, I guess, through the pharmacy system or whatever. I don't really understand that side of the system. But are you familiar with those kind of practices, and if you think that's a viable thing, or what the deal is with that?
So there's concierge medicine, which is like for the wealthy. They'll have like a doctor that will pick up his phone any time of the day and will, if you're in the hospital, show up at your bedside.
Right.
And then there's also direct primary care, which is where you kind of pay like, I don't know, $100 a month,
Okay,
And
maybe that's what I'm talking
yeah,
about.
that's another. It's. I mean, these are both very good developments, but direct primary care is one where you just you pay a subscription fee, and you can see your doctor whenever you want in their office. But
Is
it's
that?
not.
I was going to say, is that talked about? Like, do you think more of them will pop up, or do you think that's something that like it's not really talked about in med school? Guys don't really know it. People don't really want to go into it unless they have a certain bend, like a libertarian bend or whatever.
It's definitely positive. I'm definitely looking into those kinds of opportunities right now for
Okay.
a job, but there still are disadvantages. Namely, if you have to refer out to a specialist, or
You got to have insurance.
they still have to have insurance. At the end
Yeah,
of the day.
I guess they would try to do like, I imagine they would definitely have catastrophic care, and I don't know all the health insurance laws, but even for like things that aren't catastrophic that have to get referred out would have to get paid for.
Exactly. So I mean, if you refer to a specialist like a cardiologist,
Right.
is the cardiologist going to take flat fees as well?
Right.
And what about for medications? Are they going to pay for medications out of pocket? It's
Right.
unlikely.
So I think if we had a market for insurance, they would fill that need. But unfortunately, that's also highly regulated in what they can do.
Yeah. So I mean, ideally, what insurance would be, I think, and Slappy, you can probably give more insight into this. Is it should be something like a high deductible plan.
Mm-hmm.
With relatively low premiums that you reserve exclusively for things like when you end up in the hospital, or if you get some unforeseen diagnosis like cancer, like you're diagnosed with prostate cancer, and that's what you reserve it for. But your day-to-day expenses are, your doctor's visits, your labs, your routine prescriptions are all out of pocket.
I mean, I think that would be a much better model for containing costs. Mm-hmm. Another thing, and you put this in your notes, this certificate of need laws. Before a hospital can be built, it has to prove need for services. I think that's got to be a huge issue in the cost of care, that essentially you have monopoly power on a given, not really. I mean, I can choose to drive farther to the next hospital, but someone's not allowed by law to open up a hospital.
So these tend to be local laws. They're state-based. You can't, a new hospital can't be built without going to the county commission or something and seeking their approval. And so a lot of times these county commissioners will be lobbied by the opposing hospital corporations to deny that license.
I would have to imagine that those existing hospital would be pretty politically connected and powerful.
Yeah.
Like, I mean,
not too thrilled with someone open up shop.
I mean, we have a name for that system too. It's called fascism. The government,
gives certificates to who can operate. Yeah.
Yeah.
Yep. In fact, I'm looking up right now. If you look up the definition of certificate of need laws, CON programs, so certificate of need programs, aim to control healthcare costs by restricting duplicative services and determining whether new capital expenditures meet a community need. And I like that because it's so ridiculous. Control healthcare costs by
restricting access,
by restricting duplicative services. In other words, restricting competition.
Yes, exactly.
It's like saying that if I have a Denny's and an IHOP in my town, that's duplicative.
Right, and
you get rid of one of them.
Yeah, and they're going to charge more when they build the Denny's next to the IHOP because they got to do that capital expenditure. So watch out; they're going to charge you way more for pancakes at Denny's.
Yeah, exactly.
And you mentioned earlier in the episode the plastic surgery, cosmetic surgery type stuff is not covered by insurance. And last time I looked at the chart, which was a long time ago, even in nominal costs since the 1990s, a lot of services have decreased in price over that time. Nominal, not even in real terms. In real terms, all the services have. But that's pretty incredible that in 1995, you might pay $10,000 for something that today you would pay $7,000, or that's just a random number thrown out there. But even in nominal terms, the price has dropped because we have a market for cosmetic surgery. And I do think that if you applied that to other services, we would see prices come down.
Yep. Cosmetic surgery, LASIK eye surgery.
Yeah, we talked about that before on here. Last time I went to the eye doctors, I saw this stuff about orthokerotherapy, where she put contact lenses in, these special lenses that you put in while you sleep, and then you pop them out during the day, and it reshapes your eye, so you can wear it, I guess while you sleep. And I asked the doctor about that, and he pulled out a sheet and said, "All right, this is exactly how much it costs. These are the plans that we do." And he's like, it's because it's not covered by insurance, so we have to, make it competitive for people to want to buy. So it's pretty amazing what happens when you don't have that third party payer.
Yeah,
kind of in the middle of stuff.
Now they're not perfect because they still have another cause of increased prices in healthcare is occupational licensing.
Mm-hmm.
Almost everybody involved in it has to have years of schooling. Some of it may be excessive in my opinion.
Yeah. How long do you have to be in school to be a doctor?
You have to go through, after the age of 18, after graduate from high school, you have to have pretty much, with very few exceptions here and there, 4 years of undergrad, 4 years of med school, and then somewhere between 3 to 7 years of residency.
I think Doogie Howser would disagree.
Yeah, I don't know how he got started so early.
He just was a better doctor than you.
And so that adds up, right? So when frankly, when you're paying your doctor, your part of that cost is going towards the years and years of schooling
that
you had to pay for. Now, I think it's debatable how much of it is useful. In my opinion, undergrad, I had a great time in college. Went to a lot of parties, but a lot of football games. But I mean, in terms of whether it is useful to me in my current career, none of it is. All those pre-med classes you had to take were completely useless. Like no doctor is ever using organic chemistry or physics or even intro biology. It's nonsense.
Well, I have a friend of mine that is a dentist now, and like his undergrad, I forget what it was. It was I think he started as like geography and then ended with anatomy. It was just like, I just need something that looks good to get into dental school. Didn't really matter what it was, and it didn't have that much to do with with dentistry. And I know dentistry is a little bit different than other fields, but it's same things kind of applies.
Yeah, most pre-med kids do something like, I don't know, microbiology, just because it overlaps with the pre-med requirements.
Sure.
But then you got med school, right? So you've already gone through 4 years of college. Med school, the first 2 years are, book learning, tests and whatnot. And then your third and fourth year are actual clinical rotations.
Which is like, I imagine that's almost like a apprenticeship.
Yeah, exactly. And then, the third and fourth year are actually quite useful because you rotate through all the various specialties.
Mm-hmm.
Well, especially the third year. The fourth year, by that point, you're gearing up for residency and applying, so you're actually doing audition rotations at your, residency programs that you want to end up in. But the first and second year, there's a lot of stuff you learn that you don't need to know. Especially if you become a specialist, right? So if you become, let's say you end up as a psychiatrist, well, all that time you spent in the anatomy lab was useless.
Right.
And all that time you spent in histology, which is the science of studying tissue under microscopes, was useless.
Right.
So I've actually had arguments with other family members of mine that are in medicine as well about this, but I think the concept of medical school should be done away with, and it should be broken up into the specialties, just like we have dental school and medical dental school or vet school. We should have not medical school, but pediatric school, psychiatry school, anesthesia school. It kind of befuddles me how pediatric, psychiatry, anesthesia, surgery, emergency medicine all ended up as med school, but then dentists got their own little school over there.
Yeah, you're an anti-dentite too, huh?
Exactly. So, I mean, basically, I think the education should be a lot more tailored to your specialty.
Now,
I think that's
go
ahead, Rollo.
Did you know like what you wanted? Like, I know for me, for going to school for engineering, like I was mechanical engineering, and I kind of knew I wanted to be a mechanical engineer. But even within mechanical engineering, I mean, there's just like 18,000 different things you can do. So, and I didn't even really figure out what I wanted to do until I was working for a couple years. So,
yeah.
like, is that something that like a lot of, like, did you know what you wanted to do when you were going into medical school? Like, I guess how practical is that for a lot of people? Or
think
would
I
it just kind of
was-
force their hands and then you just kind of figure it out?
I guess I'm just super indecisive. So I ultimately, when push came to shove, I couldn't pick what I wanted to do because I felt like I get easily, I don't know, bored if I did any one thing too long. So then I knew it would have to end up being something broad, like family or internal medicine. You know, something very broad specialty that covers everything. And so the good thing about being family medicine is that you see a little bit of everything. I do a little psychiatry, I do a little cardiology, I do a little pulmonology, everything.
Gotcha. Okay.
Yeah.
All right, so I got to ask. I guess we're still kind of early in this pandemic, at least in the United States. Do you have an opinion on how it is being handled, or how a market could handle it better, or would a market handle it better?
Yeah. I don't really have any particular insight into this more so than I guess, whatever you're reading in the newspapers. Sure. It's causing a lot of fear. You're seeing people in clinics and emergency rooms right now, just they're all panicky about it. So everybody wants to come in and get tested. And unfortunately, there ain't enough tests at this time.
Right.
But people are trying to say like, oh, this is Trump's fault. Like we don't have enough testing yet. And I don't know if you can blame it all purely on him. I mean, it's a very unique situation. I don't know if anybody could have anticipated this.
Yeah, and I think even, just sorry to cut you off, but even in a market, I mean, you can't really anticipate these things. There would probably be at least a shortage for a while.
Yeah.
But I was reading an article, I think it was on Reason.com, about a company that developed a test back in February, but the FDA shut them down because they couldn't do it unless it was an FDA-approved lab. And that's just one example of probably several. And especially if you got rid of these regulatory agencies, that would obviously incentivize more people to do things. So we'd probably see a lot more. But had the FDA just approved the test, we may have had more of these tests, or we would have had more of these tests by now. So I think there's a lot of things like that I'm not even aware of in the medical world that the FDA controls. And, like a market's not perfect. It's not going to be utopia if something like this happened. I
don't know why you should require the FDA's permission to sell a test.
Right, a test, right? You're not providing care to something, you're just testing stuff. Like, why does the FDA need to get involved there?
I mean, that's another, huge cost in medicine, which maybe we didn't touch on, was prescription drug costs are pretty high because the cost of developing those drugs is astronomical because you have to jump through all the hoops that the FDA erects to get a drug concept to market.
And that's always the people who defend patents will say, well, it costs so much to create it, and then you're going to put in all this time doing it and then not get any profits.
Exactly.
Yeah,
the patents are necessary because the development costs are so astronomical.
Yeah, a fix to a problem that they created.
Yeah, I spent a little over a year in pharmaceuticals for a little bit before I went into petrochemicals, and man, I felt like I was working for the FDA. Like, pharmaceutical companies, there's a lot of criticism made towards them, and they deserve a lot of it. But man, the red tape that surrounds that industry is unbelievable. It was worse than nuclear red tape. 'Cause I did a little bit of that too. Like the nuclear red tape made more sense and felt less awful than the pharmaceutical red tape.
Oh yeah, yeah. They couch out to the FDA to their every whim.
Yeah, and that's why it was nice to leave the industry, because I could be like, well, I actually feel like I'm now working for the company to make a profit. I don't feel like I'm working for the FDA. Yeah.
It's like the gatekeeper to avoid punishment.
Yeah, I'm curious why more drug development doesn't move to like other countries with more lax regulation.
It's a good question.
Yeah.
Well, but even if it,
I guess I don't know.
So I know there's a girl locally who has a brain tumor and wanted to do some experimental treatment and flew down to Mexico for it. I imagine that's somewhat common. I don't know why it was not. I don't know the details. This is a story I heard from someone. So I don't know what the procedure was or what, but as this group of people were talking about it, people are saying like, well, would you really want to go to Mexico? Like, and I'm thinking, well, I mean, if the other option is dying and our system here doesn't allow treatment, yeah.
Slappy, I'd rather be dead in the
I'd
U.S.
rather be dead
alive
in the U.S.
Mexico.
than alive in Mexico. Absolutely.
Yeah.
I imagine that. No, I imagine that happens fairly often. And say this treatment did, or maybe, like, I don't know the details. So I don't know if this is going through the process with the FDA or whoever is the regulatory body around this. But say it works, and would then does the U.S. use foreign countries almost as like testing? Do you know that you know of? I don't know if you would even know that answer.
Yeah, I mean, I'm not really certain. I mean, albeit a lot of the drug development, the major corporations are all located in the U.S., right? Pfizer, GlaxoSmithKline are American. I think Merck, is Merck German?
I believe it is. I know there's a huge Merck plant, I guess, not too far from Philadelphia.
Mm-hmm.
Yeah, up in
the thing that's happening also in the the pharmaceutical drug market is that a lot of the pharmaceutical companies, they make a majority of their profits in the U.S. and then they sell the drugs for cheaper to these single-payer countries in Europe, Canada, Australia. And the reason why, so in effect, the United States subsidizes pharmaceutical drug costs for the rest of the world, because other countries have, as single-payer countries, they have monopsony power.
Yep.
So they can artificially lower drug prices. And the only reason why this model is sustainable is because the U.S. is where they make up their profits.
Oh, boy.
So
I never thought of that.
Neither did I. I never thought of that.
So the entire scheme would fall apart if we legalized drug reimportation. Because what would happen is these drugs that are expensive in the U.S. but cheap everywhere else, they would basically, the people would ship them out of Canada into the U.S. and because they'd make money off that, they'd arbitrage that difference in the price. And then you would see Canada and Europe, all of them would have shortages of all these drugs.
Yeah.
And so you often hear that. They'll say, like, why single payer is better, because in the United States, where there's a free market, aspirin costs $10, and in the UK, it's $2. Yeah. I mean, you see, that's obviously I made that up, but you'll see things like that all the time.
Exactly. Yeah.
I can't
So
wait to use that now.
we subsidize all the drug prices around the world.
That's incredible. I never thought of that.
Yeah, I mean, a lot of these single payer healthcare systems, they're able to keep costs low, quote unquote low, because of their monopsony power. They're able to basically coerce suppliers into accepting lower charges for their services, which is not sustainable in the long run. We know that kind of stuff eventually leads to poor quality and the system breaks down at some point.
And less choice, because it when there's not profit to be made, it makes people drop out of the market. Suppliers, that is.
Yeah. And a lot of these, in countries like Canada or, England or whatever, these people there have supplemental private insurance plans on top of the single payer plan.
Yeah, no, I hear that all the time, a lot too. It's such a mess, and it's nice that when we talk about this kind of stuff, we can take it right back to first principles, and it really kind of, like any other time you do it, it explains things really well. You don't need to, well, it's actually not that it's not complicated, but like people try to, pull wool over your eyes or whatever to say like, well, you just can't understand it with your simple supply and demand. It's like, well, actually.
Well, one of the things you hear a lot, and it kind of frustrates me, is people say healthcare is so important because you can't live without it. So that's why the government has to provide it, which to me doesn't address the question, because even if you died without healthcare, if there was competition, it wouldn't necessarily, it would still work as a marketplace. But the reason why it doesn't work is because we don't have competition, because the competition is regulated out of existence.
Right.
Yeah. It's like saying, I need food to eat, but we don't need government to take care of the food market because we have competition between grocery stores and restaurants and all that stuff. And even in a market like healthcare, where admittedly there's asymmetrical information, right? The specialist, the doctor, might know a lot more about your condition and could theoretically take advantage of you. So there's some asymmetrical information there. We have asymmetrical information in other markets, like
go to the mechanic.
Yeah, exactly. That's exactly what I was thinking. The mechanic. I have no fucking clue how my car works.
I know I put gas in it. I know I turn a key.
Exactly. And there's been a bunch of times I've been pissed off at a mechanic. You take it in there and it's like you change your oil gasket and it's gonna be $500.
Yeah.
But you can still, if you're not lazy, you can still shop around and ask different mechanics. And the same thing you could theoretically do in a free market healthcare system if we didn't restrict competition.
Yeah, the wrath of the consumer is a powerful mechanism for making sure that people, give good service or products and charge decent prices.
Yeah. If there was free entry into and out of the market, if anybody could hang a shingle and call themselves a doctor, then it would force doctors to be much more honest with their customers. Now, you could still have the designation of like MDs, DOs, or all the other, PAs, NPs.
And I'm sure we would, or at least some variation of it.
Exactly.
Oh, as Tobias Funke said when he got his hair plugs, no licensing, so big savings.
Exactly.
Yeah, exactly. Yep. Yeah. It drives, whenever you don't have barriers to entry that are artificially erected, then those margins tend to disappear.
Yeah, no, that's
Milton Friedman talked about the AMA and how it was created to keep competition out.
Yeah, I wrote like about my senior thesis on it in college. And when the AMA, I think it was the early 20th century, they came into effect. They passed occupational licensing for physicians, and they like in like a span of like 5 years, they closed like 2/3 of the med schools in the country.
Wow.
Yeah, and all the doctors' salaries started soaring immediately.
Wow.
Yep.
So I guess we're wrapping up here. But one more thing I want to throw out there. Have you ever watched like old movies? And I can't give a specific example, but the doctor does house calls all the time. Was that something that used to happen? That I don't know still does. I don't know that many people, unless you're like on your deathbed, I guess. I don't know how much you know of the history, but is that something that used to be common that is no longer common? And is that because of some kind of regulation?
I mean, that's what the concierge doctors do, right?
Okay.
They're the ones working for, the rich and famous,
Right.
But I don't know if that model makes a lot of sense for most people, just because the doctor has to drive to the patient's house. So that would imply that the patient's time is more valuable than the doctor's time, and which means the patient makes more than the doctor, right? So there's not, I mean, based on current salaries, the doctor is probably going to make more than most patients out there.
Typically.
So I don't know if house calls make
Sure.
a lot of sense. It probably makes more sense for the patient to come to the doctor. And then also you have other things like you have the equipment in the doctor's offices, be it, blood pressure cuffs and vital signs and various tests that they have there. So
do you know why that would be the case? And I'm assuming, like, I have no clue. I just have seen it in movies, old movies. So I imagine it's what happened. Do you know why it would have been the case that they would do that back then? Or
I just think they had
this
less,
just like a movie thing that they just put out there and whatever?
I think they just had less testing back then.
Yeah. Okay.
So you didn't have like as much equipment in the doctor's offices back then as you would today.
Right. Bring your stethoscope and you're ready to go.
Exactly.
They didn't have the
nowadays,
internet.
yeah.
They didn't have the internet for self-diagnosis.
Yeah.
Yeah.
Which makes everyone a doctor, which is what we're saying.
Yeah.
Every time anything ever I can't talk. Anytime anything is ever wrong with me and I go and Google it, I always have brain cancer.
Sorry to hear that.
Yeah. well,
the job of a doctor is they call it differential diagnosis. They take your complaint, they ask you a bunch of questions, and in their head they're thinking of all the possibilities, and then they're one by one crossing them off.
I always assume when they leave the room, they just go on WebMD and start Googling stuff.
Like if you say I have abdominal pain, in my head I'm thinking, okay, you could have a bowel obstruction, pancreatitis, gallstone, appendicitis, and then you go through and you ask them questions like
keep eliminating things,
and you cross things off, and then eventually you have a rough idea.
Don't you see the knife sticking out of my stomach?
Yeah, exactly.
Yeah.
Yep.
So one last question. Would you recommend our podcast to people?
Absolutely not.
I want it to be doctor recommended.
No, absolutely would.
All right, cool.
1 out of 1 doctors recommend this podcast. 100%.
Number 2
of doctors.
The second best podcast after Fadcast?
That's not true.
Nope.
That is not true.
Remember, we can edit, so.
Yeah, right. We can edit, and we will edit.
Okay.
Actually, that takes way too much effort. We don't.
Yeah, we're not going to do that.
Sure.
Anyway, we'll put you on the spot again.
Yep.
And it's okay to say no. Actually, it's not after you didn't initially recommend our podcast. Do you have a free market success story?
Do I have oh, man. Well, I don't see a lot of free market in my line of work.
I actually, if you don't have one, I have one.
All right, let's hear it, Rollo.
I am in the process of refinancing my mortgage, and actually, someone did make a house call today. It was the notary for me to sign on all the documents. She came over to my house and tonight actually said, "What time?"
Right now, is she a live audience?
Yeah, she's actually doing this podcast for me right now.
Oh,
she's
good.
the one. She's the one doing it. really good. Not only good at notarizing, but also really good at learning a new voice. And
Very good.
yeah,
Very good.
So hats off to Kirsten.
Hmm.
But no, it was kind of nice. It was because it's there's a lot of paperwork you got to sign, and I work like a normal work day like a lot of people, and it would be annoying to have to take a day off or take a half day to go someplace to sign off everything. On the other hand of this process, free market success story of Bitcoin. Everyone says that, and I know that the UX of Bitcoin has a long way to go. There can be a lot of improvements made, but when someone starts complaining about sending a Bitcoin transaction, ask them if they've ever sent a wire, because I had to send a wire today for the closing costs, and one, I had to go through my bank, I had to call my bank, they had to do it on my behalf, then they had to call me back and verify it. That it was going to go through, and then you got to wait for it to go through the Federal Reserve and everything, and it's kind of terrifying, especially because usually when you're sending wires, it's a large amount of money, and not only that, it was expensive. It cost $10 for this. Meanwhile, if I need to send a Bitcoin transaction, I get the person's address and I copy and paste it into my wallet software to send it. Transaction fees are pretty low these days, and also there's a checksum on it. You don't have to read it 800,000 times where you're sending the routing number and the account number for a wire. So it's I have no doubt that there's going to be improvements made to sending Bitcoin transactions around and everything associated with Bitcoin. But the legacy system, if we're going to compare apples to apples, is not very user-friendly, not very fun, and it's nerve-wracking and terrifying. So,
yeah. Well, I can think of another free market success story. With all these quarantines and self-isolation going on, I think Amazon Prime is a free market success story because a lot of people don't want to go out there and expose themselves going to a store, especially if you're an elderly person or immunocompromised. So you don't want to go out there and potentially catch COVID. So they can use Amazon Prime to get everything delivered to their doorstep within 2 days.
Yeah. Also great for libertarians that lack social skills.
Yeah. Yeah.
Not that there's any of them.
No, I mean theoretically,
Not that I'm
practically all of us.
Not one of them. Yeah.
Right.
Yeah. Sure.
All right. Well, Vake, thanks again for coming on. This was very informative. There's some real gems in this one. I had no idea. So it's always nice to talk to someone, because it's like we all think that we know a lot about the medical field because we all go to the doctor, we all take pills, we're all do all sorts of stuff, right? Yeah. But to dig into the weeds with someone that we can just ask whatever's kind of on the top of our head. It's informative. And we appreciate you coming on, and appreciate someone who kind of shares kind of where we're coming from, as far as the economics and the politics go.
Yeah, absolutely. A lot of doctors don't know the economic side of things, and vice versa.
Right.
Yeah.
So do you want to tell everyone where they can find you if they want to harass you?
You can find me on Twitter. At VAKERAJ.
Okay, we'll put that in the show notes page. We'll also link to the other previous episodes when you were on, when you gave your other area of expertise, so that's Bitcoin. We learned a lot from you early on in those days.
Yep, that's rapidly becoming my obsession. Maybe someday, I mean, to be frank, I might leave medicine in the not too distant future to go into Bitcoin professionally.
There you go.
Nice. Dr. Bitcoin.
When we did that first episode, at least half of it, you could have been speaking Greek to me. I was like, put that got the itch. That gave me the itch. So it was a great episode. I would like to listen to that again. Raul, have you listened to that one at all recently?
Yeah, I'm terrified to.
I know. I'm afraid to go back and listen to myself back then. So, but maybe I will.
Yeah. Well, with time, I mean, people catch on.
Yeah.
Oh yeah, I mean it's one of those things where it's what I try to tell people. It's like, yeah, I know it seems like it's a big learning curve and you don't understand any of it, but give yourself a little bit of time and patience, and if I can pick it up, then I'm pretty sure basically anybody else can.
I think it'll get easier as time goes on, just
Mhm.
because the resources will get better,
Mhm.
the
Well, it's like
actual tools get better.
if you tried to explain how the monetary system works currently,
Hmm.
people would glaze over and say you're crazy, but they know how to spend a dollar.
Yeah.
Well, I think it was Guy Swan brought this up on one of his episodes, and I think it's a really great example because I think the internet's a good foil for Bitcoin to say, hey, you don't really have to understand the technical details of how the internet works. You just use it. And to go even deeper into that, it's like imagine your grandmother being on the telephone with you, telling you how, oh, I don't like the internet. I don't use the internet at all. I don't need it. While she's it's voice over IP is what the making the phone call was. She doesn't even
Hmm.
know that the old system of the telephone lines doesn't even exist anymore, and that phone call is being made over the internet, and she is using the internet but never has any idea that she is. And I think it's going to be kind of the same thing with Bitcoin and any technology that emerges
Yeah.
with that.
Well, one of the things I'm really excited about going forward in Bitcoin is how multi-sig gets easier and easier.
Mm-hmm.
Because I really think that we have to transition to multi-signature becoming the standard for securing your keys. Just because it provides that additional level of security to have your keys physically distributed in different locations.
Yeah, I think because especially with I think there's a lot of scope creep as far as hardware wallets go, and they're trying to become like you know physically secure, and it's like, well, I don't know that's really the purpose of a hardware wallet, but multi-sig solves that problem,
Yeah.
and it can be used in tandem with hardware wallets very
Hmm.
very well. So yeah, I think the sooner that happens, the better. So we stop focusing so much time and energy on something that's hardware wallets is physical security. I think is a real dead end, but there's not really
Yeah.
much
There's
of a better solution right now. So that's what everyone's trying to go for. But no,
every
I agree
hardware
about.
wallet is just waiting to be hacked,
Yeah, or
basically.
two,
So,
it's just if most people they have a hardware wallet and they have their seeds written down, and their
mhm.
seeds are probably written down somewhere in their house. So if someone gains physical access to your hardware wallet, they probably have physical access to your backup seeds too.
Yeah,
So
yeah. You have them in
like
the same place.
yeah, I mean, hopefully you do a little bit better of a job with that, but
Yeah.
it's that's where multisig comes in. That solves that problem.
Yep. Well, there are those it's like crypto steel and those like those steel
Mm-hmm.
cases where you can engrave your seed in. Sometimes you can put those like you can bury them somewhere.
Right, right.
Yeah. So those are other options.
Absolutely.
Yeah.
So again, Vake, thanks for coming on, and show notes page for this episode where you can find Vake's Twitter handle and also his previous episodes. If you want to go back and listen to that, will be mcfluel.com/188. Also, be sure to check out libertymugs.com for all your coronavirus needs. And all right, so thanks for listening, and we will catch you next week.
Peace.
Later.